Okay, I think we should get started. It's 8:01. Thanks for joining us, everyone, for this session. A reminder not to disclose any private health information during your case presentations. This is our usual assistance and contact information. You can contact Rick for any IT or technical issues, or Andy or me for any other issues that come up. And just some history about cardio. It's hard to believe it's been 6 years. And this is the team, of course, all of whom I think you're probably quite familiar with by now. And I will be presenting today and facilitating as usual. I've asked Jim and Danette to comment on our case. We only have one case today, so we can extend the discussion of the case, or we can end a little early depending on how it goes. But Megan will be presenting our case this morning. And our usual disclosures, these have not changed. And I'm going to talk to you about empowerment, something I'm really passionate about. And those of you who know me, I think we have about, Kelsey's on our research team, we have about 2 or 3 studies over the last few years that have used the word empower in some way or the other, including one with the Department of Urology. So we'll talk about what it means specifically and how it's relevant to practice today, especially among those with cardiovascular risks in underserved communities or those who belong to disadvantaged populations. So the learning objectives this morning are define patient empowerment, describe empowering patients to seek high-quality care for the prevention of cardiovascular disease, and describe an approach to patient empowerment within a busy primary care practice. So this is not disease specific. It doesn't pertain to diabetes, hypertension, et cetera, but those are very common illnesses for which our patients need to be empowered. And that's why we'll discuss them in that context. We can talk a little bit about gaps in care to start with, to set the stage. So we know that among patients with diabetes and established cardiovascular disease, so these are the patients who have the highest risk for having a cardiovascular event. Only about 58% have controlled blood pressure. So more than 40% do not have their blood pressure controlled. And you would think that if there was any population among which this would be important, this would be a top priority population. But the question is why? Is it because we have a lack of guidelines to help us control blood pressure? No, that's definitely not true. Those have been around, they've been established, they're helpful. Is it because there is a lack of quality measures and standards, associated provider incentives? That's absolutely not true. So in my health system, for example, the percentage of patients who have controlled blood pressure is a significant quality measure for which there are financial incentives tied to physicians. Is it because we have a lack of innovative models of care? In other words, do we not have the means? Do we not have the approaches that we can adopt in order to control blood pressure? That's not true either. And this is a statement from a federal report. There's no lack of tools, programs, models of care, many of which are linked to financial incentives for physicians for their effective use, available to improve quality, and the lack of such resources cannot explain widespread quality problems in the United States. So what does? Well, let's talk about that a little bit as well. So the first thing that often comes up, and this term has been around, I think, about 20 years, is clinical inertia. And that is the failure to establish appropriate targets and escalate treatment to achieve goals. But it is only present if there are 3 conditions that are met. One is there has to be a certain implicit or explicit guideline. So if it's for blood pressure, for example, we have to all agree that the target of 130/80 is reasonable. If I disagree with that and I don't believe in it, that's not clinical inertia. That's just my own heuristics or my own paradigm. The second thing is I have to believe that the guideline applies to the patient. And this is a problem sometimes. So even though 130/80 is a target, sometimes I'm just grateful for my patient to show up and to take their medicine sometimes, right? And their blood pressure may not be 130/80, it may be higher than that, but the guideline in many cases should apply to the patient. And the physician has the resources to apply the guideline. Resources also include time. Okay, if the patient comes in and they've got chronic pain, osteoarthritis, type 2 diabetes that's uncontrolled, and their blood pressure is 140/92, when they come in. I don't have time to deal with that right now. So if all those three conditions are met and the physician does not follow the guideline, then we say the clinical inertia is said to be the cause. Why does this happen? Well, it can be for many reasons, right? It often takes us some time. So I like the word inertia, but let's not link it to motivation. It's often the circumstances in which we practice overall. So I'm looking at the list of folks here. Looks like, hey, Austin, you're our only primary care doc besides me. So let's say Austin and I are in practice together, and I see one of his patients, and he's on vacation, and the blood pressure is too high. It's above target. And it's like, I don't really want to intensify his treatment because, it's Austin's patient. And I'll say, come back and see Dr. Friedrichsen next time. So the patient comes back to see Austin, maybe 3 weeks later. And Austin's thinking, well, Dr. Rao didn't intensify the treatment. He must have had a reason for it. Let's just watch it for now. He comes back. Then he goes back on vacation or he's at a conference. He comes back, sees me. I said, well, Austin must not have felt it was necessary. He knows this patient better than me. It goes back and forth. So there's years, this has happened for years. And I've gone through chart reviews. And the underlying cause is sometimes we're overwhelmed by other priorities. And we believe that we have time to do these things. So those are some of the factors that influence clinical inertia. It's certainly not a lack of guidelines or belief. Let's talk about another reason why we don't achieve the targets we set out, and that's patient factors, and it's poor engagement with care. This is so common across the healthcare system, especially for some populations. You probably hear that birth outcomes are poor in certain populations, and they're related to poor follow-up for prenatal care. And that applies for a lot of different things. And there are reasons why patients may not be engaged with care. They may have a limited interest in self-management, including lifestyle modification, especially because so many of what we deal with in cardiovascular risk management requires the patient to be engaged. And then there are system factors. There's time and productivity pressures. There's times you simply forget. You simply forget to refill that medication or simply forget to intensify treatment because you're too busy. And our primary care structure of acute visits is very poorly designed for management of chronic illnesses such as type 2 diabetes. So these are some explanations. We have come up with solutions. The chronic care model, I believe, developed by Ed Wagner, I think it's more than 30 years old. And not saying it's flawed, but it doesn't really capture what's happening in America today. So what it says is that when you have all of these things in place, you will get an informed, activated patient, productive interactions, and a prepared, proactive practice team with improved outcomes. Well, we all know where we practice, we have community resources, we have self-management support, we can redesign our delivery systems. We certainly have decision support and clinical information systems. So this is more than 30 years old. And often our patients are not informed and activated, right? So the assumption that if we just put things around our patients will respond to it makes absolutely no sense. And then we talked, I think a while ago, if we just provide healthy food in our communities, our patients will go out and eat it and they'll be healthier. That's not true. It's never been true, and it's not true for how we manage chronic disease. We have to have a completely different approach. And I spoke about this, trying to think of who was there. None of you were there last week at a cardiovascular conference in Cleveland. But let's move on. So the solution has to be something new. We don't need clinical redesign. We don't need more alerts saying your patient's blood pressure is too high. Yes, I know it. Click, just turn that damn thing off, sort of thing. I don't need, I finished residency in the 1990s. They used to mail physical guidelines to us, right, in the mail. Right, the AFP saying, "Hey, here's your blood pressure guidelines," and it's like, "Are you crazy? I'm getting all this mail." It's like that's not going to make any difference for me whatsoever, right? So these things will not work. So here are some new concepts, relatively new concepts. When I say new, I mean in the last 10, 15 years, that may be applicable to the problems we face. One is called shared decision-making. So it's an approach where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. A shared decision-making discussion may go something like this. Your type 2 diabetes is out of control. I've maxed out your dose of metformin to 2,000 milligrams a day. We're not going to get more out of that. There's new classes of medications that are out there. There are some limitations with them. What do you think about it? You want to discuss it further. And then you go through them and say, well, this one has a lot of nausea and vomiting as its side effect. This one maybe give you, vaginal yeast infections, whatever it happens to be. Where do you feel about this? And these are the risks. Let's talk about it together. I would say a lot of our discussions now do follow that course. It's much more so than a couple of generations ago, when you would just say, "Hey, this is the approach I'm taking. Good luck to you, and we'll see it." So shared decision making isn't taking place, but it has to be a formalized process. The concepts I'm more excited about is one called patient activation. It's a patient's willingness and ability to take independent action to manage their own health and overall care. There's strong evidence that more activated patients have better outcomes. So more activated patients with diabetes are more likely to perform foot checks, obtain eye examinations, and exercise regularly compared to less activated patients. And informally, we all know that this is true, right? Someone who is interested in what their blood pressure was, someone who's interested in what their hemoglobin A1C was, takes out a little notepad and notes it down, and says, "What was it last time, doctor?" That's a patient that is very invested in their own health. Okay, so if you have an activated patient doesn't have a particular appearance. Like, I've noticed that a lot of our case discussion patients are older white males who live in small towns in Ohio, who are unemployed, who have few social supports. That doesn't mean they're not activated or not interested. You cannot tell who it is, right? Because people are invested in their health for many, many different reasons. So it's not fair to say that men are less activated than women, although, you can make that argument there, or that patients as they get older naturally become less activated because I think they accept that poor health is part of aging, which we find as well. And that's not necessarily true either. So let's keep that in mind. So a patient's baseline level of activation really is something that influences their health. And Jim and I know this from Fit or Me, that probably the best predictor of how well people do in terms of weight loss is how motivated they are when they come in, right? Do they ask good questions? Do they make notes? Do they make their appointment on their way out right away? Are they invested in discussions that take place? That is all a positive predictor. So we're not here to talk about those concepts. So we talked about clinical inertia as a barrier. We talked about how we overcome it, the traditional methods of overcoming it, which do not work. I'm not going to say they only work a little bit. They just don't work at all. So the definition of insanity is doing the same thing over and over again, expecting different results, right? So we need a new approach. So related to activation and shared decision-making is the concept of empowerment. This definition comes from Europe. It's defined as a means to promote autonomous self-regulation so that the individual's potential for health and wellness is maximized. Now, it's kind of an obscure definition. What is autonomous self-regulation? Autonomous self-regulation is your ability to manage your own affairs, right? In whatever capacity. If you are empowered financially, right, it means you're able to manage your credit card statements in a way that allows you to live optimally. Okay, if you are empowered linguistically, it means you can communicate with people in your community, of course, in a way that is meaningful. So if you are empowered in terms of health, you have to have a different set of skills as well. So this is the European Patient Empowerment Campaign. So the EU has had a patients forum. This is about 3 or 4 years ago, and they adopted this charter. Now, not all of it, I think, is all that insightful. So I am more than my health condition. I am empowered to the extent I wish to be, which I think is important. I'm an equal partner in all decisions related to my health, which is shared decision-making. This is an important one. I have the information I need in an easily understandable format. My health professionals and our health system actively promote health literacy. I have the ongoing support I need to manage my own care. That's an important one. And the other ones are how a patient can contribute more broadly to the healthcare system. So my experience is a vital measure of healthcare quality. I can participate in evaluating and co-designing healthcare services, patient organizations. My voice becomes bigger, and equity and empowerment go hand in hand. I want a fair deal for all patients. Let's keep that one in mind. Okay. So let's move on. Now, I want to make something very clear. So that definition of empowerment is a little bit obscure. It's a little bit hard to grab. If I ask each of you, are your patients empowered? You'd say, well, some of them are, some of them are not. Some of them are just cranky, which doesn't mean they're not empowered, right? They can be very empowered, right? And some of them are very quiet and very, very adherent and very pleasant. And that doesn't mean they're not empowered either. But here's a really important discussion. Empowerment is not necessarily related to how you perceive your healthcare to be. Okay, that is not what empowerment is. So here's a very influential survey from the Pew Research Foundation from last year. And it talks about one of the groups that we care for here in Ohio in significant numbers, and those are Black adults, African-American adults. And it talks about what their perception of healthcare is. Okay. And, and this is all Black adults. This is men, women, upper income, lower income. There's not a big difference, right? And there's not a big difference between Black adults and other adults. And 40% of Black adults say they've had to speak up to get proper care. There are some small differences here. Sometimes they are better off. You were rushed by your healthcare provider, 32% versus 39% overall. These are not huge differences. And one might say, okay, wow, we don't have a big problem here. This is very encouraging. And if we did this with another population we care for, whether maybe it's rural adults, maybe it's Latinx folks, maybe it's people with disabilities, maybe it's LGBTQ folks, I don't know if you'd find differences or not. Right. So I have a mentee, Elizabeth Harris, who's in our department, and she's studying the experience of urinary incontinence among older African-American women. And I warned her in advance, you may not find a disparity in diagnosis or management before she started looking at the data. We assume there's always a disparity, and there wasn't one. But that's not empowerment, okay? You can be the least empowered patient imaginable and walk into an office and walk out and say, my doctor's wonderful. He or she did absolutely nothing for me today. I didn't get anything I wanted, but that's okay. I feel good about it. That is not the same thing. Empowerment is your ability to regulate your health, to meet your health goals, and to maintain optimal health. Okay. Just because people think their care is good does not mean they're empowered, and does not mean there's not a problem there. Let's keep that in mind as we go through this discussion. So, how do we empower patients, and what does it mean? Okay, you cannot say, okay, I want to empower you and say, I want you to be proactive in managing your health and expect that to happen just like that, because people don't know how to do it, right? You probably, if one of us goes to see a physician or we have a family member, you just imagine how empowered we are, right? I used to manage something called the UH Select program, which is for VIPs. They pay extra money for it. I wasn't a provider in the program, but and those folks are really, really empowered. They're waiting on the Epic MyChart for their lab test result to come back, and then they've got questions about it as soon as it does. So that's unusual. So that's sort of the intrinsic empowerment we spoke about before. That's intrinsic activation. The bigger question is, can we empower our patients in some way with some tool? And this is something I've been trying to do. We had the Empower study in urinary incontinence. It's just one of those examples. It's not cardiovascular risk. And I've said this so many times in so many echo sessions over the last 15 years. The most effective tool I have ever developed in pediatric and adolescent hypertension is a sign in a waiting room that says, ask your doctor about your child's blood pressure. That's all it says. Some parents come in and they ask, some don't. Sometimes the doctor says it's fine, and it really isn't. But quite often that's much more empowering than clinical decision support, lectures to patients, public service announcements, anything of that sort, because some people will feel empowered. Wait a second, it's telling me to do that. It must be important. So can we broaden that concept to some of the illnesses we care for? So we came up with this checklist, I think about 4 or 5 years ago, called the Empower Diabetes Checklist. It's based on other measures, and it's been tried out, that sort of thing. If you look at these things, these are just things that a doctor ought to do. So what you might do is you have a patient who is coming in for a diabetes checkup, or you can send this out through my chart. And of course, the majority of patients are not going to fill it out. Some will fill it out partially. Some will fill it out and forget to bring it with them or not discuss it. And on the other side, some doctors will say, I don't need this. I already do all these things. It may feel a little threatening to some people, but in general, if we implemented this sort of thing system-wide, we would probably improve the quality of care. So has your doctor discussed improving control? Has your doctor talked to you about changing or adding medicines? Did your doctor talk to you about other medications to prevent heart disease? So this focuses on the newer medicines, your blood pressure, your cholesterol. Did he or she talk to you about your diabetes? Smoking cessation, checked your urine, checked your eyes, a flu shot. These second questions come from a primary care measure that has now been adopted by the National Quality Forum. Does your doctor know who the most important people in your life are? And does your doctor consider all the factors that affect your health? Okay, so you fill this out, let's say in the waiting room, you crumple it up, put it in your purse or in your bag or whatever. But there's going to be a few questions that will probably remain, and when you get into that encounter, and that might be helpful to empower some patients. It can't hurt, since what we're doing now doesn't work at all. So I think that this is the underlying concept of empowerment in action. Now, let's think about, this is complicated in a sense. It doesn't seem like a whole lot to check yes, no, and to empower a patient in that way. What can we do to empower patients? In other words, this might be a system sort of thing, and system-based approaches are problematic because you have to have the buy-in of people and physicians. And when physicians say, for example, I always talk about smoking cessations with my diabetic patients. I don't need this questionnaire, and I don't need my parent and patients to fill it out. It makes it really tough. But there are subtle things that we can do to empower our patients significantly. And I've talked about this in other contexts as well. Here are 3 examples I hope you will consider, if not adopt, because I think they're very helpful. We often ask, do you have any questions at the end of a visit? We encourage our students and our residents to ask that question at the very end. And sometimes it's kind of lip service. Sometimes it's just a routine thing. Sometimes we'll look at a patient and they look a little bit confused, or we, through the encounter, believe that they haven't understood things. And so we ask them, do you have any questions about your visit? The most likely response is, no, I'm okay. I'm good. That's not empowering a patient, okay? A better approach is to say, what questions do you have about your visit today? And this stop and wait. Because it does, first of all, it empowers the patient for them to say, it's okay for me to ask questions. The patient is expected to come back with a question. And it's less likely they're going to say, no, I don't have any questions. What questions? I have none. That's an unusual response. So I encourage you to adopt that language. What do you believe you need to better manage your diabetes, hypertension, high cholesterol, whatever it happens to be? Rather than, here's what you need to do to better manage your diabetes, which of course is a bit of a patronizing approach to it. It doesn't encompass shared decision-making. I'm going to put you on this particular medicine. Here's what you need to do to better manage your diabetes. What do you need to do? What do you believe you need to do? That would be a better way of asking the question, because it's not putting a burden on them. It's empowering them to tell you what they need to do. And of course, you can say, okay, that might work or that might not work. How can I help you achieve your goals versus you need to be more consistent in taking your medications? Your goals are to improve your diabetes so you don't feel so tired all the time. You're not going to the bathroom all the time. so that you don't get complications. How can I help you achieve your goals is the way to ask that question. So these are 3 empowering questions. You don't need to use a complicated checklist. But the thing is that I think that is important, and that you can come up with many, many more of this type, is that you're giving the patient an opportunity to seize control of some aspect of their health. And that's not what we do right now. We go around the room. It's like, the patient is the elephant in the room, and we say, oh, we're going to build clinical decision support. We're going to have them engaged in this and that. We're going to focus on the provider, the system, quality measures, incentive payments. All of this is going to overcome our lack of engagement that we observe among our patients, and that's not true. So they need to be empowered to do their own health. The last thing I'll say is, we can think of empowerment as a form of social justice, right? So we talk about food deserts and poor food supply, and none of that has ever worked. You can't provide healthy food in the community, put up a supermarket and expect people to be healthier. What's been shown is that, we said a few weeks ago, is that they'll tend to buy more unhealthy food at lower prices when you put up a supermarket in a poor community. And that's not the impact you want. But when you talk about it in terms of social justice, and you say, these companies, these food companies, this unhealthy food is being promoted in your community, and it's making the community sick. And do you want to contribute to that? And the answer usually, of course, is no. Well, I want to empower you to say, look, just reject it, reject that food. When we talk about chronic illnesses like diabetes, if you say to a patient, there's a whole new class of medications out there, it's been around for a few years, of course, they're much more effective in controlling your type 2 diabetes. They'll help you lose weight. Plus, they'll help prevent heart disease and heart failure and those kinds of conditions. And you really are entitled to, you should be on that medication, just like patients in wealthier communities, in suburban practices, et cetera. You should be it, and you should be on them, and you should ask your doctor about them. That's also a form of social justice. In other words, our patients are entitled to the highest quality of care, regardless of where they live or who they are, right? And they're not getting it. So I think if you point that out to them, hopefully that's also empowering as well. Okay, I'm going to stop there and see if we have any questions before we move on to our case.
Not a question here, Dr. Rao, but a quick comment, if I may. I was struck by your description of what a provider does, 3 or 4 things in front of him or her, and control of blood pressure may be low on the list. It seems to me it's really the same thing on the other side of the table, because when you're talking to the client or the patient, he or she has 3 or 4 things that they're concerned about, and controlling the blood pressure is low on the list. So when you combine those 2 things on both sides of the table, you kind of, there's your definition for lack of success. But what a question or a comment I would like to make, if I may, and I'm going to sound redundant. Many of the things I've heard you say are commonsensical, obviously, but I admire and I respect your need to be assertive about saying them, because if you don't say them, people don't take them seriously. What I find to be an impediment to success is a disconnection between understanding what blood pressure is and what the long-term results are.
Yes.
Our clients just don't have the opportunity, for whatever reason, to understand the connection between what is and what we do today and what's going to happen 5 or 10 years down the road. It confuses the heck out of me, because they understand the importance of the sequelae, but they just don't seem to be able to make that connection. I'm just wondering if somebody can help me better understand that.
Yeah, so I can comment and others can comment as well. Great observation, Paul. So who is more empowered? I said you can't tell just by looking at a patient who is empowered and who isn't. That having been said, the more highly educated a patient is, the wealthier they are, regardless of their race, ethnicity, sex, gender, whatever, the more likely they are to be empowered. And the underlying economic theory behind that is that they do more long-term planning because they have more to protect. If you're on Medicaid, if you're on social assistance and you're disabled and you're living in a small town by yourself and you've got no social supports, tomorrow every day is a new adventure, sort of thing. And so a disease like hypertension in particular, where your doctor's saying, if you don't take your medicine every day, you might have a stroke within 5 years, doesn't resonate as much as somebody who has a family, a well-paying job, a house, maybe a second house, and they're coming in with their notepad and saying, gosh, I need to get this under control because my kids are going to college in a few years. It's a really different philosophy altogether. There's nothing we can do to change the circumstances of our patients, but that's one rationale that's been put forth for the phenomena that you've described, and it's very common as well. Okay, any additional comments about either Paul's comment or anything else?
This is Karen. I mean, our diets are so high in sodium, and so that contributes to high blood pressure, because when you look at older societies with lower sodium intake, they didn't have blood pressure problems. So our increased weight and our high sodium intakes are important, and that's something that when people look on a label and they see 50 milligrams of sodium, or 150 or 800, they often don't have any context as to what they should be eating. And the food companies are very interested in that. Nobody wants their product to be put back on the shelf. So there's mass confusion, the labels are confusing. So I think, just, constant education about, well, maybe looking at foods and, if it's above 500 milligrams, 600 milligrams for the meal, that's kind of high. I mean, just trying to put numbers in perspective. And the other thing that I think about with societal change is the smoking campaign. Smoking was advertised as something healthy a long time ago. Their newscasters smoked, so people didn't realize that it was harmful. And it took a combination of education and legislation to really make changes. So buildings started saying, well, if you work here, you can't be smoking. You have to smoke outside. I think we need to do the same thing with the food industry, because there's no way the food industry is going to change their profit seeking methodology, which is including more sugar and fat and salt and buying cheaper food and making products that are unhealthy. I just feel like it's going to take a combination if we want to really change society. And then the other thing I'm thinking too is when you put a grocery store in a low-income neighborhood, those people that live there may have a whole generation of really not doing much cooking. So they've kind of engineered their days to where they don't even think about having time for food preparation. But that doesn't have to stay that way. It's just increasing awareness in those communities that it's worth it to make foods at home. These are the reasons why. Absolutely. Let's talk about some things. So
yeah, great comments, Karen. I may have said this in a previous echo. From a social justice standpoint, let's think about African Americans. I had an African American med student back in Pittsburgh who did a project. He was also an anthropologist, so he was an older student, and talked about the history of catering among African American companies in big cities. In the turn of the 20th century, most of the big catering companies were run by African Americans in Philadelphia, Baltimore, Washington, D.C. Cooking was a huge tradition. So he was talking about his grandmother cooking a lot, his mother cooking a little. He's, of course, of higher income, so he and his wife cooked a fair bit, but he's seen it disappear. Why? It's not a cultural thing. McDonald's is not part of anyone's culture. It's been pushed upon poor communities by these large food companies. So when you make that, he was making that case saying, we need to get back to the traditional ways of thinking of eating. It does resonate with at least some people, for sure. Okay, thank you, everyone. We're going to turn it back to Andy for a moment.
Just as a reminder, you can see all past and present echo clinics on our website. And then next slide. Just a reminder that I sent out the post-clinic survey. I don't think we've been having issues with people receiving them, but please let me know if you didn't receive it. Otherwise, feel free to email me with any questions, and we will see you next week.
All right. Enjoy your week, everyone. Talk to you soon. Bye-bye.